Good afternoon, everybody. We're going to get started. It's 11:40, and we have a lot of great information to share this morning. So we would like to get it started. First of all, I would like to welcome everybody to the Prenatal and Infant Care Network, our quarterly luncheon. I'd like to thank DuPont Hospital, who graciously is underwriting the food for all of us today. So many thanks to them. I also want to recognize a steering committee of individuals who are a lot of stakeholders in this room who have volunteered to help us put together quality panels for you all, and they're all recognized at the bottom of the paper. But if for those who are on the steering committee, if you're here in the room, would you please stand up for a moment? And Aaron from Parkview, Paige Wilkins, there are other people that are not standing up at this moment. So I would like to just say thank you to them and just realize that this is a great community effort to identify what are key issues to come in. And we look closely at the survey responses that you give us what you want to hear more from. Traditionally, to start this meeting, we would like to have everybody introduce themselves. And the caveat of this is you have to do this really quickly so we can go through the room, but we want to know your name, your role and agency, and if there's any kind of an update or a one sentence of what you guys are doing, you want the others to know. It would be great to just know the resources in this room. So I am going to start over here, and we're just going to pass the mic, and I'm going to ask you to stand up. Today's presentation will be taped, and so if you find the information helpful, as I am confident you will, you can go back and look at the video of this. It will be on our website. We will send a link to all of you afterwards so that you can see this good information as well and reference it pretty easily. And that's been based upon feedback from others in the past. So let me get this going where we can introduce everybody in the room.
In my mouth. I'm Patty Bryce, Senior VP at for Women and Children at Parkview.
Gwen Carpenter, Program Manager, Parkview.
Jill McAllister, Community Health Improvement, Parkview.
Hi, I'm Jackie Martinez. I'm a supervisor at Healthier Moms and Babies, and something new to our organization is that we have added to our team. So that's really helpful in expanding our services. You will hear from them. We are now serving Noble County as well. Thank you.
Erin Norton, Director of Outreach for Women's and Children's at Parkview.
Hi, I'm Lisa Cotton. I'm the Director of Development for the Children's Health Collaborative. Something new, we're back up and running, and we're looking forward to collaborating with all of you to help impact infants and moms and all the kids in our community. So feel free to reach out to me.
I'm Janet Elmer from DuPont Hospital, prenatal, postnatal educator and community outreach.
I'm Kathy Detweiler. I am Nurse Navigator at Parkview Health.
I'm Stephanie Good, DuPont Hospital, childbirth education and community outreach.
I'm Danielle Furge. I am a nurse home visitor with Healthier Moms and Babies.
Tara Stoops, also with Healthier Moms and Babies, nurse home visitor.
I'm Madison Lyon, Development and Administrative Coordinator for Healthier Moms and Babies.
Shirley Lothamer, I'm a supervisor at Healthier Moms and Babies.
Maria Martinez, Case Manager at Healthier Moms and Babies.
Teresa Michelle, translator interpreter for Catholic Charities and Park Center.
Erin Harold, I'm a nurse with Healthier Moms and Babies.
Belia Diaz, Case Manager with Healthy Moms and Babies.
Ashley Nichter, Case Manager with Healthier Moms and Babies.
Chelsea Harris, also a Case Manager with Healthier Moms and Babies.
I'm Maria Charlin, a nurse with Healthier Moms and Babies.
I'm Kayla Grazzini, and I'm also a nurse with Healthier Moms and Babies.
Paige Wilkins, Executive Director of Healthier Moms and Babies, and it makes me so happy to have all these wonderful staff.
I'm Eric Shoemaker. I'm one of the family medicine residents at Fort Wayne Medical Education Program. Okay, so I will be joining Parkview August 1st at their new office at the Summit, right next to Healthier Moms and Babies. So.
I'm Alicia Shaw. I'm a case manager with Healthier Moms and Babies.
I'm Danielle Krimple. I'm with Healthier Moms and Babies. I'm a nurse home visitor.
And I'm Julie Reese. I'm also a nurse home visitor with Healthier Moms and Babies.
Hello, I'm Brian White, Executive Director at Give Here.
I'm Melissa DeSania. I'm the Executive Director at Mad Anthony's Children's Hope House, and we are going to be opening up a suite of rooms at DuPont Hospital in about 8 weeks. So eager to serve the NICU and PICU and PEDS families that will be staying at DuPont.
Hi, I'm Kara Casavan. I'm a project manager for Chip-In for Quality, which is also some work done with IU School of Medicine, Department of Pediatrics.
Hi, I'm Whitley Wins. I'm a lead quality improvement coach with the Chip-In project under Kara.
I'm Gina Dundon. I'm the wellness coordinator for Fort Wayne Community Schools.
Patty Leslie, nursing coordinator at Neighborhood Health Clinic and same-day access to prenatal care that you'll hear more about in a minute.
I'm Courtney Winker. I'm the nutrition coordinator at the Allen County WIC office.
Ty Nakabal, Neighborhood Health Clinic SWIC Director.
Angie Zagel, CEO of Neighborhood Health Clinics.
Hi, I'm Heather Hunley with the Lutheran Foundation. I'm project coordinator for lookupindiana.org, which is a mental behavioral health website that I hope you're all aware of. And we are in the process of developing a page for expecting mothers. And so all things mental behavioral health related to pregnancy. And so I'm currently kind of gathering resources, vetting resources. So if you have anything, email me, heatherlutheranfoundation.com or.
Hi, I'm Katie Clay with Goodwill Industries.
I'm Stacia Roth with A Mother's Hope. Little update, we've been open 8 months now. We've had 11 moms that have been housed and 6 babies, and we do have open beds. Wanted you all to know that.
I'm Emily Thiel, lead resident advisor at A Mother's Hope.
I'm Leanne Fritcher, the Director of Nursing at Hope Center, and we just are getting ready to open a new center in Columbia City on June 4th.
I'm Ashley Weiland, also with the Hope Center, and I'm the Director of the Medical Mobile.
I'm Diane Hess, also with the Hope Center. I'm the Center Director at South Calhoun.
I'm Sarah Gargak with the Hope Center, and I'm the Center Director at Hobson Road.
Melissa Hall, I am the Maternal Recovery Specialist with Parkview Health.
Frederica Rogers, I work for Parkview as well, and I'm a peer recovery coach.
Steve Jagla with the Women's Care Center, Director of Outreach.
I'm Teresa Clark, and I chair layouts for the Christ Child Society, and we're in 24 agencies and looking at getting into Whitley County now. So we've added that to our Angola and Auburn areas.
Hi, I'm Jean Wagner. I'm co-chair of layouts for Christ Child Society of Fort Wayne.
I'm Deb Lully, and I'm the supervisor for Parkview Community Nursing.
I'm Loretta Bogle. I'm a nurse outreach. I work with moms and babies out in the community with Parkview Community Nursing.
Hello, everyone. My name is Anthony O'Gunson. I'm working at Parkview Community Nursing. I'm a community healthcare worker. I'll be based off in the Rescue Mission for the Men.
Megan Testa and I work with Healthy Families.
Kai U, community health worker with Parkview Women's and Children's Outreach.
Jocelyn Shi, community health worker with Parkview Women and Children Outreach, Safety Pin.
Kirsten Bailey, community health worker with Parkview Women's and Children's Outreach.
I am Shelley Meredith. I'm the infant toddler specialist at Early Childhood Alliance.
Nan Malloy, outreach specialist for Early Childhood Alliance.
Tricia Willard, Center Administrator for ECA's Children's Centers at Early Childhood Alliance. Hello, Lanissa Maggart with Early Childhood Alliance. I'm our Family Engagement Coordinator.
Hi, I'm Carrie Eyrich. I'm with Director of Hope and Harriet Recovery for Women and Their Children with the YWCA.
Alice Kupfer, St. Joe Community Health Foundation board member.
I'm Christine Meek. I'm the Vice President of Grant Making at the Community Foundation.
Marty Martin, Catholic Charity Community Service Community Case Manager.
Hi, I'm Nancy Swigonski. I'm your speaker today.
I'm John Pearson. First and foremost, I'm impressed, very impressed by everybody that's here and working in this space. I'm a consultant to United Way of Allen County for public policy and the new executive administrator for the Alliance for Human Services of Northeast Indiana. And the one announcement I would like to make is we're bringing the documentary 0 Weeks to Fort Wayne on June 18th. It is about why paid parental and family leave is a good idea for the United States and families in Indiana.
I'm Deb McMahan. I'm the Health Commissioner, also known as Dr. Debbie Downer, and you'll know why soon.
Deb is never a downer in my life. I'll tell you, she's. Thank you all. And I just always am reminded by all the wonderful resources and the fact that if we all work together, can refer to the other expertise in this room, you know, we will get that infant mortality rate down to where we want it to be, and a lot of families will benefit. The next thing is from Neighborhood Health Clinic has some great news to share, an issue that was identified in the community. But do you want to come up here, if you could, please, Leslie? And this kind of grew out of some conversations, I think, between Safety Pin, Footprints, about an opportunity in the community, and Neighborhood Health Clinic really stepped up and responded. And can you share what's happening?
Yeah, we're up and running. We have already helped several people. Basically what it is you come in and you get a pregnancy test, and if it's positive, you're offered to have same-day services that day to have prenatal care right away. If the residency program is not there on an OB day, we have nurse practitioners that have been trained, and they'll go ahead and they'll do the first exam with the history and the physical exam as well. So it's just like our set appointments that we have for prenatal patients, where we have social services available. We get them hooked up with WIC and all the services that we can offer them at one time. They're offered all those same things at the point of a positive pregnancy test.
I just think that is a huge accomplishment. I was looking at the statistics, 38% in 2016 of the population of new moms were unable to get early prenatal care. So if you run across one of those moms, get them to Neighborhood Health Clinic, and in one day, we can really get them enrolled in wraparound services. So again, thank you to Neighborhood Health Clinics for really finding a way to make that happen. Next, we actually have not Dr. Debbie Downer, but our very wonderful health commissioner, Dr. Deb McMahan, who's going to kind of give us an update on the health of Allen County families.
Before you start, I asked where the neighborhood health clinic is located.
Yes, I would like the people from Neighborhood Health Clinic to talk a little bit how to do referrals.
We have the sky bridge that goes over from a parking garage over to the old Troy Laundry Building. So we're just south of Lincoln Life.
You want to just give your address one more time so I get on the video.
1717 South Calhoun.
Okay.
Is that it? Ready? All right. You want me to just use this? You may need it later. So if you'll be kind of run around. Okay. Well, first of all, boy, it really, I have to agree. We really have an impressive list of resources here that are available to folks. And this is just for children by and large. You can't imagine what your colleagues that are dealing with grown people actually have to offer too. You know, when I was asked to talk about the health of families in Allen County, I started really thinking about a lot of different things. And first of all, there's not a lot of data on the health of families. So we're going to have to kind of look at the health of adults and realize that's probably the future if we don't make some significant changes. But I want to start the presentation before I get to the really depressing stats. And first of all, just kind of some random thoughts as I was putting this together. Okay, so I didn't even have a title for this set of slides because it's other than random thoughts. But first of all, I really want to make sure that we are really all on the same page. And I'm sure you guys in this room are really all on the same page, but a lot of other people don't realize how encompassing the definition of health really is. Most people think of it as you're healthy or you're not healthy, and they think of health as really just the absence of hypertension and et cetera, et cetera. But really, it's a sense of well-being. That's really what you're trying to achieve with your patients, whether you're a physician, you're a social worker, you're a nurse practitioner, you're a pharmacist, whatever, all of us in healthcare. And I use the term healthcare very broadly. When I think of healthcare, I'm not just thinking of medical providers. I'm thinking of all of the people that it takes, the team of people it takes to make a person feel like they can get up every day and live their best life. But first of all, I have a question. How many people in this room, and I want honesty, I don't want, just to be politically correct. How many people in this room truly believe, how many people have seen the news in the last few weeks? Okay, first of all, so having read the news, watched reality TV, done everything that you've done in the last 2 weeks, how many people still believe that everybody is born with potential? Raise your hand. Okay, good. All right, well, hold that thought, okay? I actually think that the World Health Organization did a pretty good job getting the definition, but I really have come to appreciate as a physician how important spiritual health is. I think that's really an important part of the definition of health. And I hope you all agree too, because when I look at some of the challenges facing some of the people you see every day, I can't imagine how they do it in the absence of faith, honestly. I think sometimes it takes that supernatural power to be able to get through some of the things that some of our people face every day. So that's just my thought. Always have to talk about, and I'm glad I put this slide in here because Dr. Dawson's here and she would reprimand me after, raise your hand, Dr. Dawson, would reprimand me after the talk if I did not mention the fact that social determinants of health are really also important. And I think we've really come to appreciate it's where you live, how you live. Social determinants really encompass really the environment that you live and work in, quite frankly. And that we really know now that really has a huge impact on the health of a person over the course of their lifetime, from childhood to adulthood. And again, it's the social environment, it's the physical environment, it's health services, your access to health servicer, but all sorts of things that probably we don't even really recognize every day when we see our patients and our clients, the things that they're living with every day. I have to mention this, a colleague of mine just had a baby. And to cheer me up, because we're having all these outbreaks of horrible infectious diseases, to cheer me up, she'll periodically send me a little video of the baby, and I watch that baby, and I realize it brought home to me how vulnerable they are. How absolutely, completely helpless they are. She's like 2 months old. And then I think about the environment that I'm going into to provide some of these public health services, and I'm thinking of that helpless baby in that environment. And it's really motivating me to get this community on fire, to really begin to provide an environment and a system of care that really allows kids to really have the kind of childhood we really want them to have. I love this quote. I use it almost every time I talk anymore because you don't realize it until oftentimes you don't have health, or someone that you know has loved something. Either they've died or they've really been given a diagnosis of cancer. But really, health really is the foundation of everything. It really is. And you only have to look at your own life to see on a day maybe when the night before you maybe had a Super Bowl night and you got a little partied a little too much, didn't get enough sleep, and the next day you were crabby at home, you were crabby at work, you didn't meet your deadlines, you didn't do everything, versus a day when you got a good night's sleep, you wake up and you just feel on fire, you're going to go out and save the world today. A lot of that is a function of physiologically how well you're feeling. Did you get adequate sleep, hydration, food? Do you feel safe, secure? Do you feel motivated? Do you feel like you have a purpose in life? All of those things, when they align, that's when you are going to see maximal productivity. And what we want for our families that we serve, what I want for our community, is just not even 100%. More often than not, do you feel productive? Do you feel well enough to be able to go out and live your best life and realize that potential I think you were born with? But it's hard to do that when you don't feel good, whether it's mental, physical, both, social, you have trauma at home, it doesn't matter. All of that impedes that ability of you physiologically. We know now, and Dr. Swigonski, are you going to talk about epigenetics a little bit? She's going to tell you why we know now that that environment is impacting how well you feel to go out and live your best life. When I look at the conditions some of the people that I'm serving are living in, I can't imagine how they have the strength to get through a day, let alone live their best life, let alone do the hard work of realizing their potential. So this really is what you do, and you are a member of the healthcare team. If you're in this room today, you are a member of the healthcare team. And what you do is vital to the productivity and the ability of your patients to realize their potential. And again, what we're seeing now is so much illness, so much burden of disease, and not just Indiana, but the United States. We're seeing it really impact productivity. We have the lowest labor participation rate ever of men, ever. They're not working. And this is between 18 and 54. This isn't people that should be retired. Dr. Shoemaker, do you really like your job? Good, because you're going to never retire. You will work forever because you're going to be supporting these people because they're not working, but they're still having families. So, and I don't know that that's just that these are willful, bratty people. I think these are people that don't feel good physically, mentally, probably a combination of both, that just don't have it in them to go out there and work. But that's not economically sustainable. And again, this is what you and I are trying to do. Again, it doesn't matter what you're trying to do. We're trying to get that balance. I love the picture of homeostasis because I think that's the picture of strength. It's not like this. It's not muscles. It's balance. True power results from strength, from balance, from homeostasis. When all things in your body, mentally, physically, electrically, chemically, are all aligned. That's when you really have the power to go out and realize your potential. You are a flesh bag of chemical electrical reactions. How many chemical reactions do you think you have every second in your body? Just someone take a guess. I'm not going to go on until somebody takes a guess. 1,000. Try 400 million chemical reactions in your body every second. It's amazing, actually, how little goes wrong when you really think about that. I mean, every time I drive through McDonald's, probably 1 out of 10 times something goes wrong, right? I get Coke instead of Diet Coke. But you have 400 million chemical reactions every second. And look how healthy you are here today. It's amazing. But that's what you and I are trying to do, is just create balance in all of those domains. Whatever domain you touch in a person's life, you're trying to restore balance. Like I said, there's not a lot of information on family health. And most of the indicators on children's health are really talking about obesity and smoking. But you really can get an idea of family health by looking at parental health, because children's health and parents' health are very strongly associated. There was a study that really looked at that, and if you're interested, to get the slides and research the study. But it really looked at how closely associated parental health was with their children's health. And it's through a number of ways, and Dr. Swigonski is going to touch on that. But a lot of it is genetic, a lot of it is environmental, and a lot of it is social. And one of the really good examples is parental depression. There's a genetic component to it. There's a social milieu, the environment that a child who's living with a depressed or anxious parent or is living with, that environment that they're living with, all of that leads to a marked increase in the probability or the risk that that child is going to have depression as well. So we know that if we look at parental health, we have a good idea of what the children's health is and will likely become. Why do I belabor this? Because again, like I said, I don't have a lot of indicators on family health. But I think it's really important to note that what this study realized also that I just referenced is that there's an interconnectedness, and that if we can improve the parental health, we're also improving the children's health. And that's a twofer. And a lot of you, it's so nice to hear what you're doing. In fact, most of you in this room are actually doing that. You're doing a twofer by working with the parents, by not ignoring their needs, by just focusing on the child, but rather by focusing on the whole family. Or I learned a new term the other day, the dyad. Does everyone know what that means? God, I didn't. They were talking about a dyad, and what are you talking about? The mother and child. By focusing on that, you really are getting a twofer out of that, so congratulations. But now the Debbie Downer part starts. This is actually where we look at our stats, and we do have a lot of issues. And I'm going to go through these pretty quickly because I know you want to hear Dr. Swigonski. When we look at state health rankings on an annual basis, we can see that when it looks at access to care, so dentists, mental health providers, clinical care, we're out of 50 states, this is where we rank. So you can see that access is still a problem for people. When we look at children in poverty, we did have an improvement, and we have fewer kids living in poverty in Indiana, but we still rank 29th. Violent crime, it's 30th. Air pollution, 44th. When we look at housing, again, we still have some significant issues with housing. Specifically, this is something that actually Meg Disler brought to my attention. I kind of didn't believe her for a minute. So I went and looked at it, and she's right. Fort Wayne is ranked 13th in terms of eviction rate in the nation. And that creates a whole host of problems I'm sure you all know about, or that Meg will tell you about in the future if you haven't discussed it already. I can't believe Meg and I have been working together for 20 years now, and this is what we started on. It's still a problem. These houses that are unsafe, they're like really the yellow canaries for kids for bad housing. How do we know a house is contaminated? Not because we're proactively going out and looking. We find out because a child is screened for lead poisoning, and then we go back retrospectively and then identify the house. We have a number of houses that have poisoned so many children in this community, and it's because people don't own their homes, or if they do, they can't afford to do the remediation. It's very, very expensive. God knows, Meg, we tried some cheap ways to do it, didn't we? And that did not work. It's a very expensive proposition. So what happens is poor kids live in old housing that's contaminated with lead paint, and when they get lead poisoning, their IQ drops a few points. You know, it's really it's very sad that we're still dealing with this in 2019. Food insecurity, 1 in 5 kids. That is so hard to believe when you see all the ads on TV about food, when you see all the restaurants in Allen County, and to think that 1 in 5 kids here in Allen County doesn't have food security, doesn't know if today I'm going to have enough to eat. I just can't understand how that can happen in the United States of America. I mean, we really need to think about how that can actually happen here. We still have food deserts in Allen County. Move on to health outcomes. I'll let you read this on your own. Are you going to give them copies of the slides? So when I was looking for updated, I always go out periodically and look for updated data. So first I went for the Trust for America's Health, and they said Indiana's public health outcomes generally lag those of the United States. So I decided I'll move on to another site. So I went to the United Healthcare rankings, and we didn't fare much better there either. But just looking at some of the health outcomes that I know you're all interested in, and these are our ranks in 50 states. 44th in smoking, 39th in obesity. We're not very active. And of course, whenever you have obesity, diabetes follows. This is something that Fairbanks School of Public Health really did a great job looking at obesity in Indiana. It's a great reference. If you click on the reference at the bottom of the page, you can read the full study. But it was really good, really looking at how many people in Indiana have obesity. And we actually have the 12th highest rate among adults in the country, 11th highest rate for children in the country. And more than 13% of Indiana's youth from low-income families are obese before they reach kindergarten. And that's kind of like pretty much, you're a pediatrician, Dr. Swigonski. Does that mean a kind of a lifelong issue with obesity? I mean, a lot of us got a little chunky as we got older, but this is now a problem for young people as well. And I don't know if you can see that very well, but the bottom line represents obesity. And the top line is overweight. And what's really frightening is a lot of people used to be overweight, but what has really increased are the number of people that meet that definition of obese. And obese puts you in a category for really high risk for not just diabetes, but all sorts of other things, certain types of cancers, obviously arthritis, and all sorts of things. So it's really frightening that we're just not getting more and more overweight, we're getting more and more obese. So that's a big issue, especially for our children. And this is just the age distribution from the study that Fairbanks did looking at obesity. And like I said, probably 15 years ago, that would have been really skewed to the right, kind of older people. It's kind of a sedentary older people, lose a lot of energy phase of life. But now you can see it's becoming more like a bell-shaped curve, which is not good. It means it's becoming a younger person's issue. And again, I'm going to move on that one. You can look at that. Looking at the prevalence of diabetes, again, it shouldn't be any surprise because I just told you we're the 12th highest obesity rate, but you can see we really struggle with diabetes. Diabetes, I think a lot of people have in their mind sort of simplified it, and then you just take a pill. Diabetes is a very, we're learning a very complicated disease that has a whole host of things that I don't think we've even realized yet, the implications that diabetes has on the health and well-being of a human being. And it is so difficult to manage for most people. This is really a problem when that becomes to be such a common medical problem. And I think a lot of that has been because we've kind of, again, tried to simplify, oh, it's just diabetes. It's just sugar. You just take a pill. It's really not that simple. Tobacco use, if you can believe it, this is still in 2019, this is still an issue in Indiana. 22%, we actually increased, 22% of adults in Allen County smoke cigarettes. They are so expensive. I don't know how people do it. I really don't. Actually, Indiana is ranked 44th in the country for the prevalence of adult smoking. Costs so much money for smoking. But this is where I really think for those of you who are younger in healthcare, this is really going to be your big issue in the next 10, 20 years. And that's these e-cigarettes, especially the Juul. The Juul has just exploded. And I actually see, I don't know how they get away with advertising on TV, but now they have these great advertisements on TV that they're safe, they're an alternative to smoking. It has nicotine. Nicotine is one of the most addictive drugs there is. And most people, most young people, I think it was something like 60% of young people don't even realize that it has nicotine in it, let alone how addictive nicotine is. So it's really, this Juul is something you guys are really going to have to be aware of. Most of you, how many people here know what a Juul is? Raise your hand. Yeah, you'd be surprised how many parents don't. So those of you who work with families and parents, you want to talk to the parents about that, because a lot of middle school kids, about 5% of middle school students are doing it. And the reason is because it looks like a flash drive, and I don't know if you know this, but it doesn't create a plume. So they can do it and nobody knows what they're doing. So that's why this is becoming very popular among not only high school students. 1 in 5 kids in high school are using these. And then 5% of kids. And this is really, last year was a huge increase. And so the FDA is really looking at how do we start reining in these Juul, these e-cigarette makers. But the other thing is, I've just recently heard is that what they're making are now cartridges that have THC in them and sadly meth. And so they're using those in the e-cigarettes, and people don't know what they're doing. So when you see people in a car, like the other day, I saw people trading an e-cigarette. I'm not stupid. I know what you're doing in there. They think they're so smart that we don't know what's going on. But I tell you, this is really going to be a problem, because this is another story for another day, but THC is not benign. I know we've tried to make this like marijuana. Oh, it's just pot. It's just Fast Times at Ridgemont High. This has a very significant impact on a child's brain. And so this is not a benign thing that they're making THC cartridges. Again, I don't need to talk about that. Oh, Kathy, that's your dynamic. Kathy Thornton, you want to wave your hand? Yeah. Well, who wouldn't want to raise their hand for STDs? Yeah, she's in charge. Don't be shy. She's the director of our STD and HIV prevention, and these numbers are courtesy of her. But you can see, this is we like to have some sex here in Allen County, because unprotected sex, I might add, because you can see the. Do you want to explain your slide, Kathy? Outpacing ourselves. Yeah, our numbers have increased. And Kathy and I went back and looked just back to 2014, which is 5 years ago. We have doubled our numbers. So one good thing that we're doing, trying to compete with the rest of you guys, and Paige, you're like on fire with the Healthier Moms and Babies, but we're going to get a mobile unit so that we're going to, I can just imagine 10 years from now, Fort Wayne's just going to be a series of mobile units driving around offering all these services. But we're going to get a mobile unit to kind of partner with the rest of you to be able to get to these young people who I don't think we're getting to now for the STDs. When we look at who these STIs or sexually transmitted infections are occurring to, it's the young people, the 29 and under. Although we are seeing more adults coming in there, my age coming in there for checks, but it's still predominantly a young person's disease. I think it's really important to remember too, when you have an opportunity to talk to young people, we're seeing more and more where the phone is really a connection to people to explore things that maybe they think about, but they don't want to talk to their peers about. You really have to begin to think, how is the internet, the access to anonymous, easily available, cheap services impacting your population, because it has dramatically impacted what we do. A lot of people are having anonymous sex now. They don't even know who their contacts are. So we can't even do our contact investigations as effectively. But if it's impacting my world, it's got to be impacting your world. So think about how the internet and that, especially the anonymity, can be affecting what you're trying to accomplish. When we look at I get back to the state health rankings, we're 33rd in drug deaths, 42nd in frequent mental distress, and 43rd in infant mortality. And mental illness to me is such an easily treatable condition that I think can really lead to a downward spiral to people, because the good news is you are physiologically wired to want to feel good. The bad news is you are physiologically wired to want to feel good. And if we don't do our jobs to realize what's standing in the way of that, whether it be mental illness, whether it be undiagnosed diabetes, whether it be whatever, if we don't diagnose that and get people to the effective treatment, the internet will provide a solution. And almost always that solution is inauthentic and will make them feel better in the moment, but will only complicate their life. So this is really the key. How many of you regularly, and you don't have to raise your hands, but think about how you regularly check in with people to figure out how they're doing. A lot of people don't know what they're struggling with. You have the opportunity to make a difference, and you don't have to treat everything that you identify. You just have to be able to be the mechanism, the vehicle by which somebody gets to somebody that can authentically address their problem, right? So this is a real low-hanging fruit as far as I'm concerned. And when we look at this is what's going on in Allen County. In 2017, we had a 45% increase in accidental overdose deaths. You don't hardly ever hear about that. And look how that outpaces motor vehicle accidents and homicide deaths. So again, this is a big issue. And the biggest thing, the takeaway from the people who died, and this could be the same slide I would have up for death by suicide. We had a 45% increase in that as well. These are young people. These are people that are not only employable, but these are people that are leaving young families behind. What's happening to these kids where one parent or both has either died from a drug overdose or is being impacted by addiction and the kids are being taken away? We're going to have a whole generation of kids now that are being raised by grandparents and know that they're second to drugs to their parents. That's going to be a big thing. All right, I'm going. So the big question, what I really want you to think about, and what I was hoping to have a discussion with, but what I really want you to think about is, what I ask myself is, I know most of you in this room, I know a lot of other people, and I know that my colleagues are not only compassionate, but they are competent. They're not just nice people. They know what they're doing. I know that people are wired to want to feel better. Why are we 41st? Because we're 41st in the state. When they look at state rankings, we're 40th. So why, in the midst of all of these programs, and this isn't a criticism, this is a genuine question, we're missing something. Something has to change, because you can't have competent, well-intentioned, dynamic people who are growing their organizations to meet your need. You have people who have needs and want to feel better, and yet somehow it's not happening at the rate at which we need it to happen, because we want everybody to be productive, taking care of their own families, raising their own families, realizing their own potential. Why is that not happening? I wish you as groups, as organizations, would go back and discuss that. And maybe not even just but why as a community? I'm open to ideas. I'd like to know why, what's the problem? And with that, I'll turn. Now you see why I'm Dr. Debbie Downer. Dr. Swigonski is going to fill your head with good, new, exciting news. So I'm glad we're ending with her.
Thank you, Gary.
Deb, thank you again. All the information I learn every time you talk, and I will get better at trying to answer that question, and hopefully all of us around the room can think about that. So we're very fortunate to have a health commissioner who cares as deeply as Deb does. So thank you for all the extra effort you put in to help us become better at what we do. Next, I have the privilege of introducing Dr. Nancy Swigonski. I first had the opportunity to hear part of this presentation, I'm not sure how much is the same, at the Community Foundation had hosted a luncheon, and a group of us saw this and felt we really wanted you all to hear this information. Dr. Swigonski has a resume and so many accomplishments that I would be taking the next hour to cover them. So I'm going to ask her to briefly touch upon her expertise as it relates to what she is doing and sharing with us so you'll understand what it is. And I'm going to turn it over to you, Dr. Nancy.
Thanks, Meg. Is this working? Doesn't quite sound like it. I just turned it on. Testing. Now it is. Okay. Thank you all. So a little bit about my background. I'm a pediatrician by training. I have lots of different interests, as you can see by the initials after my name. I basically am a nerd, And one of the things I want to warn you about is that you were brought here a little bit under false pretenses, because what I'm really going to talk about is neurobiology. And most people wouldn't come to a talk if they said, please come to lunch over a talk on neurobiology. Okay, I will just use this other thing. So we're going to walk through early brain development and its impact really on children and the impact in a little bit on families. So I'm going to go through several points, and we do this very rapidly. And as I say, I never let people read this first slide because I go through things one by one. And the first really is that the brain grows rapidly in the first 3 years of life. And what this is supposed to tell you is those 3 years are extremely important. Everybody, I think, has seen a head circumference growth chart whenever you take your newborn or a 2-year-old child into the doctor. They measure the head size. And what we're really doing is measuring brain growth, right? As the brain expands, the head size increases. And the baby's head size doubles in size in the first year of life. Doubles in size the first year of life, and you have about 85% of the growth of the head by the time you're 3 years old. So what's actually happening? Well, if you look at this slide, which is a cross-section of neurons, what you see is, first of all, a lot of little dots, right? The neurons. But as you look across this, what do you notice about the neurons? What you should notice is, in fact, they're pretty much the same. And in fact, you're born with most of the neurons you will ever have. What is different, though, is the connections. And that brain growth early on is all about rapid growth of those connections. So now we're going to pivot a little bit and talk a little bit about genetics. So the second major point here is that genes serve as a blueprint for brain architecture, but there's something called epigenetic mechanisms that determine what gets turned on and turned off. So everybody's heard about DNA, right? What's interesting is, of course, it's the same in every cell. It doesn't matter whether it's a skin cell, a lung cell, a heart cell. Your DNA is the same in every cell. But what is different? It's actually what gets turned on and turned off. So there are information on top of the DNA in each cell that turns some gene expression on, say, please, you become a heart cell, or please become a lung cell. And it silences others. It says, no, 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 you're not a skin cell. You're a lung cell. And there's different biochemical mechanisms that support that turning on or silencing of some genes and others. So the big field of science, honestly, now is epigenetics. We now have mapped the human genome. And I was one of those naive people that said, oh my gosh, when we map the human genome, we are going to know everything there is to know about human disease. Totally wrong. Totally wrong. And one of the best ways this was ever explained to me was, think of your genes or your DNA as a piano keyboard, right? Black and white keys, they're fixed, they don't change. But depending on what you push, you get Billy Joel or Chopin. And the possibilities are infinite, right? Things get turned on and turned off all the time. So one of the things we've learned that is fascinating is that these epigenetic mechanisms not only occur during fetal development, telling your heart cell to become a heart cell or your lung cell to become a lung cell, but they also continue after birth and are influenced by our environment and, in fact, our experiences. We've known this for a while, really from animal models. This shows that the environment, actually the temperature, causes different expression of the wing patterns in these moths that are genetically identical. There's a very famous mouse experiment. These two mice are genetically identical twins. They have, though, something called the agouti gene. And the mouse on the right, the mother was fed a very nutrient-rich diet, and that gene was able to be silenced so that the agouti gene, which the mouse on the left expresses, does not occur, right? So the mouse on the left has obesity, they're prone to diabetes. I think they're also prone to cancer. Genetically identical, but because of this epigenetic phenomenon, the way those genes are expressed is different. This happens in humans. We can have identical twins, one of whom has autism, one does not. Identical twins, one that develops cancer, and the other that does not. So what we actually see is as we go through our lifetime, our DNA starts to get tagged. And as it's tagged, it begins to express things differently. And this is an example from Novo of 3-year-old identical twins and comparing a strand of their DNA. And what you see is, for the most part, these look very identical, meaning that the yellow areas are similar. By the time identical twins are 60 years old, their DNA has been tagged differently so that the red areas show where there's hypomethylation, or one of the chemicals that tags the DNA and tells it whether or not to express, or hypermethylation, which is where the green areas are. So what does all this epigenetic stuff and this brain growth stuff have to do, and how do we make them intersect? There's really an intersection of neurobiology and epigenetics that determines the brain architecture, right? What happens is circuits and connections that get used get stronger. As we give that stimulus, then there's an epigenetic phenomenon that says you grow stronger. We want more of you. If you don't use it, in fact, they get pruned. So in cross sections, what we see is at birth, again, we're born with our neurons, but we don't have a lot of connections. By the time that we're 6 years old, there are a lot of connectivity in the brain between the different neurons. An interesting thing happens then, though, is that some of these connections, as we mentioned, aren't being used over and over again, and so they start to go away. There's actual pruning of the pathways. And I always jokingly say, and this is not true, but it's probably the reason for adolescence is we're losing our brains. That's not true, okay? That's a joke. But what it does mean is something very interesting in terms of child development, is that there are very sensitive periods in child development. And again, there's some things that we've known for a long time, and that is that there's not only sensitive, but in some sense critical periods for vision and hearing. One of the things that will happen is if you go into a physician's office and the child's toddler, one of the things we check is the light reflex in the eyes. And what we're looking is to see if there's strabismus, or a little bit of crossing of the eyes. We're looking for a weakness in the muscle of the eye that makes that gaze disconjugate. The reason that's so important is if you do not fix that weak muscle, by the time this child reaches 3 or 4 years of age, that child will never have normal vision in that eye. There is a critical pathway between the eye and your occipital cortex that has to form in order to have normal binocular vision. And it has to occur about the time the child's 4 years old. So are there other sensitive periods? And we do call these sensitive and not critical because we know that we can continue to learn other things throughout our lifetime, but that it's easier during certain times. So let's talk about two of these very important sensitive periods, again, happening in the preschool ages, right? One is habitual ways of responding. The other is emotional control. I always ask people to think about if I had a 2-year-old in here and they laid down up here and had a temper tantrum, what would you all think? They're 2, right? I mean, 2-year-olds have temper tantrums, but guess what? Look at this. By the time a child is 6 or 7 years of age and sitting in a classroom, we actually expect them to be able to deal with some of their frustration, right? Without laying down on the floor and having a temper tantrum. That part of emotional control actually starts and is very sensitive during this time period. What about habitual ways of responding? So one of the things I just did was look at Dr. McMahan and raise my eyes and look at her, and she acknowledged me. I didn't say a word, right? We know that babies and moms, dads and moms learn to respond to each other very quickly and very easily. And you have to develop this, and we're going to talk some more about the thing called serve and return a little bit later. But when this doesn't happen, when these early years of responding and habitual ways of responding don't occur, then children can develop attachment disorders. So where they don't know how to appropriately respond to another in terms of a relationship. We most often hear that in children who have undergone a lot of trauma in their early years. So when you look at other things, such as language, symbol development, peer social skills, and numbers, those sensitive periods actually extend. So what we're really looking for when we're talking about early child development is this social emotional control, recognizing that if you have this, these things are much easier. You have a foundation built for learning. This is the fourth point, and I kept trying to figure out how do I make it even stronger. This is the bottom line takeaway from this entire talk, and that is as early experiences can change brain development. So again, how do we know that? Well, we certainly know that from mice models. This is an experiment where a mouse pup was just raised typically, or the pup was actually put in a tube and isolated, not for long periods of time, but for I think it was 2 hours a day or something like that. But that's very stressful to be away from its mother and to be isolated in a place where they can't get out. And what you actually see is the typical environment led to lots of neurons, dendrites and connectivity here. But the mouse that underwent what we would then consider toxic stress actually has markedly fewer, and they seem a little less organized. So there's something going on, we know from animal models, when you get put in a stressful environment. What about this slide? This is a PET scan of a 3-year-old child. This is the healthy child, and what these areas are areas of metabolic activity. And what you see compared to the child who had severe neglect is that there's markedly less red or activity, and there's even areas where it seems like things didn't form well. So we have defined stress, which can affect brain development, in 3 ways. So one is positive, which is really a brief increase in your heart rate, mild elevations in the stress hormones. And in fact, positive stress is called positive stress because sometimes we learn better when we're under a little bit of stress. What about tolerable stress? Well, tolerable stress can be things that are severe, even a loss of a parent, but they're temporary in the sense that you may have another nurturing parent, another tight relationship to build onto so that the child continues to have the nurturing to adapt to the situation. And toxic stress is really a chronic, prolonged activation of stress response systems in the absence of positive relationships. So this is the model that we think of is when you have stress in childhood, you actually activate your hypothalamic pituitary axis. That will be a quiz question at the end, which is really your fight or flight. It's the adrenaline activity. And this cortisol inhibits, just like it did in the mouse, this brain architecture or growth, which then leads to additional hyperresponsive stress, and then it becomes a vicious cycle. So what are some of our data that really talk about this? This is a study that's part of the ACEs, or Adverse Childhood Events. This is a group of children who were in foster care. So 100% of them were considered to have maltreatment. But then they measured other things that were adverse in their environment. And they included things such as having a teen mom, living in poverty, having drug or alcohol in the home, actually even being African American. In this study was considered within their adverse events. And what happened was there's a linear relationship between the number of risk factors and the chance that a child will have developmental delay. So by the time you had 7 risk factors, these children had 100%. 7 risk factors in your environment, you have a 100% chance that you will have developmental delay. So I wanted to talk a little bit about neglect or deprivation because, in all honesty, I think that sometimes it's not talked about enough. And I'm not talking really in the legal sense. I'm going to talk more in terms of what we think of it as researchers or scientists. And so it's defined as the absence of sufficient attention, responsiveness, and protection that are appropriate to the age of and needs of a child. Because we know that healthy development can be threatened not only by what happens to children physically, verbally, or sexual abuse, but also by the absence of sufficient amounts of essential experiences that are required for their positive well-being. So this slide always kind of scares me, but what it is they tested children in problem solving. And what they found was that the children who they defined as having neglectful environments actually performed worse than children with physical abuse, verbal abuse, and of course worse than the children who didn't have maltreatment. Neglect is a major problem and under-recognized, but probably you all see it all the time. So early experiences really matter. So virtually every aspect of early human development, from the brain's involving its circuitry to the child's capacity for empathy, is affected by the environment and experiences that are encountered in an accumulative fashion, beginning in the prenatal period and extending throughout the early childhood years. So that's all a little bit scary, honestly, right? So that's the Debbie Downer part of this. So, but I'm going to give you a little bit of evidence to show you that these experiences also can do other things, right? But before we do, I wanted to talk about this one group that I'm a little concerned about. Because when you look at our slide about rapid growth and pruning, there is a subpopulation where we're concerned that this pruning may continue. All right, so let's let's talk a little bit about how do we learn? How do we shape the brain? And we saw how we can shape the brain in really detrimental ways. How do we shape the brain in really positive ways? And the most common thing that people talk about is this serve and return relationships, these interactions that actually shape that brain architecture. So when an infant or young child babbles or gestures or cries, they're basically serving or sending out a signal. And what happens then is an adult or whoever they're with may respond. And if they do it appropriately with eye contact, words, hugs, smiles, that's the return. And what it does is strengthen and build those neural connections that support the development of communication and social emotional skills. So just came out yesterday, John sent this to me. The Center for the Developing Child at Harvard sent out a video of 5 steps that you can use to encourage this serve and return. So when you're working with families at home, these are the things that you should watch for and help families do. Since this will be on the website, there's like a 6-minute video that's well worth watching. It's really great. But what they say is really what you need to do is encourage parents to notice the serve. What is the child trying to tell you? What are they paying attention to? And you should share the child's focus. If a child's looking at something, you look at it as well. You could point to it. You should let them notice that you're noticing what they're interested in. The next is return the serve by supporting, encouraging, right? The child points to a book. Oh, you saw the book. Should we read the book? Get that back and forth. Serve and return interaction going on. Give things names. Book. I just did it naturally. Take turns and wait. This is some of the hard part sometimes. You have to wait then for the child's response. Parents shouldn't take over the play of a child. They need to see what they're interested in, take their turn, and allow the child to move on, to take their turn, or to keep the interaction going back and forth. And then I love this one. It's one that I hadn't seen before. And it's practice endings and beginnings. One of the things that we often have trouble with in preschools and even in schools is transitions, right? How do you get kids to move from one activity to the other? And in fact, they show really great examples of how you can do that at very early ages and start to give children words to help with that. One of my favorite things and ways that children live this is from the American Academy of Pediatrics. And I actually did a lot of reading about trauma-informed care and other things like that when thinking about this talk. And in the end, I ended up just putting this slide up here because in the end, for me, this is what it boiled down to. Children need routines. They need to know what to expect of us and what we expect of them. Reading together daily, that's so important. Rhyming, playing, and cuddling should be a routine part of every child's life. You should give rewards for everyday successes and praise. Just saying you did a good job putting your toys away is a great reward. And then relationships, which we've talked about, that should be reciprocal and nurturing. The CDC talks about safe, stable, nurturing relationships. This is the foundation that you need in which for this serve and return learning to work. So children should feel safe, free from fear, and secure from physical and psychological harm in their environment. There should be stability or predictability and consistency in their relationships. And there should be that nurturing that we talked about. So, do we have science to support some of these things? Well, I used to show this slide pretty much by itself and say, look at this. When we have children who live in poverty compared to children who live in professional families, the kids in professional families speak almost twice as many words as the kids in poverty. And the answer in this article was, we think that there's a 30 million word gap between what the kids in poverty are hearing to what the kids in the professional families are hearing, right? So if you think use it or lose it, and some kids are hearing lots of words and others aren't, then that's going to be a big difference. Well, that's honestly a little bit depressing because I can't go out and cure poverty. I'm going to try. I'm doing things to try, is the truth. But the cool thing was this came out not long ago. And what they said is, you know what? It's not really the number of words. What it is they actually measured and did MRIs and showed the activity in the brain. And what they really showed was that it's the conversation. It's that serve and return. So if you're having conversations with your child, it doesn't matter whether you live in poverty or whether you live in a high income family, it's the back and forth that made the difference. Now, kids who live in poverty tend to have fewer back and forth conversations, but we can take care of back and forth conversations, right? We can encourage parents to read to their children, to interact with their children, to have that serve and return and talk with their children. So there's something we really can do about it while we're curing poverty. This is another really cool study that I just love because I think it gives us lots of hope. So these were kids who had growth retardation, meaning they were stunted, between the ages 9 and 24 months in Jamaica. And they did a trial of nutritional support plus or minus psychosocial stimulation. And what they found at 22 years of age was that there was really no benefit of the nutritional supplementation, that even though they grew a little bit better, the long-term outcomes really weren't better. But when the kids that were randomized to get the early stimulation, where they had worked with the parents on how do you interact with your children, they were 36% and 33% less likely to be involved in fights, violent behaviors, had higher IQs, and had better educational attainment and less depression. Again, interacting with children and helping parents do that serve and return interaction. Last nerdy slide on this topic, okay? But this is another one that I absolutely love. This is crazy. This is crazy. So this is a group of kids that were being evaluated for depression, and they were ranked whether they had low depression scores or high depression scores. And then they were given some tasks to do, and the mother was to help the child do the task. And they rated the mother on how well she supported that child in her task. Okay, this was in preschool children. Then they did MRIs when they reached school age, around 7 years of age. And this is crazy. So if they had a lot of depression and the mother didn't offer a lot of support, this was the size of the hippocampus. See, neurobiology school. Hippocampus, remember, emotional control, short-term memory that leads into long-term memory, which is learning. This was the volume or how big it was. When you had low depression scores in a child with a lot of mother support, look how big that hippocampus is. It's huge. But even in the kids that were depressed, if the mother was highly supportive, this is actually, even though it looks kind of big, this was a not significant difference in size of the hippocampus. So it really says maternal support and interaction with that child affects the hippocampal brain growth. Does that not blow your mind? Seriously, cool stuff. All right, this is a study I always include, and I'm going to look at the time real quick. because one of the things that we know is, especially with children who may have some deprivation in their lives, one of the things that's recommended for them is to go to high quality early childhood care. So I always include this study. It's old, but it is something called a meta-analysis. And a meta-analysis takes all the scientific studies and uses statistical means to combine those studies in a way that we can make conclusions beyond any one of the studies, if that makes sense. So this meta-analysis really was going to ask three questions. They studied two different kinds of intervention programs. So one was parent education and family supports through home visiting, and the other was early childhood settings, or a combination of the two. And they asked three questions. One was, are high quality early intervention programs effective? What are their attributes? And do we get a return on our investment? Do we get a bang for our buck? And this is the kind of programs that they were looking at this time. And again, there are other programs now that are evidence-based, but this was the meta-analysis. And the bottom line was, they said studies going back 30 years have shown that intervention in the first 3 years can improve outcomes. Period. What are the kinds of outcomes? Academic achievement, behavior, educational progression and attainment, meaning do they graduate, decreases in delinquency and crime, and they're more likely to be employed. So when I hear sometimes people will argue, especially about this one, because there's some studies that don't show academic achievement, and I just, honestly, I sort of laugh and go, okay, I'll give you that one because I really care about these, right? Whether a child gets an A or a C in third grade, as long as they grow up to graduate from high school, to not be in jail and to have a job, I'm okay with that. So, interventions with more favorable results had better trained caregivers, smaller child to staff ratios, and parental involvement. No surprises there. And do we get a bang for our buck? Absolutely. Depending on the program, it ranged from $1.80 to $17 for each dollar spent. And this is just an example of some of the programs. I always tell people that one of my favorite is the Perry Preschool, because I actually have one of my best friends whose daughters went through that. She was a single parent of two little girls living in Michigan, and they enrolled her in it, and she went on to get her degree and became a nurse practitioner. And they still follow her and those girls to see what happened. Now they're now about 40 years old or so. And as I say, one of them is a real success. She lives in Arizona and she's a social worker. The other one, you can make your own judgment, but she's a therapist for some of the stars in Hollywood. All right. So early experiences shape the architecture of the brain. Development of the brain incorporates experiences, whether positive or negative. Brain architecture establishes a sturdy or weak foundation for learning and behavior with lifelong consequences. So closing thoughts here. Early childhood development affects us all. One of the interesting things that ever happened to me is I went to a grand rounds. There's a guy by the name of Robert Duggar there giving a talk, and he's an investment banker. And I'm like, okay, why is an investment banker here? And he was talking about early brain development and why the business community needed to get involved. And he gave this statistic: 75% of 18-year-olds cannot get a job as a private in the U.S. Army. And he didn't actually have the reference, and I didn't believe him. So, like Dr. Mahan, I had to go look it up, right? And you have to be a little careful about statistics. So these are the 18-year-olds who are showing up at the recruitment office. These are not the ones that have already gone and signed up for college or already gotten a job somewhere else. So it is kind of a narrower population. But even so, think about it. 18-year-olds who want to serve our country, who want to be employed, who want a job, and they cannot. And these are the reasons. lack of diploma, health problems, which you just heard about, like obesity, asthma, actually dental caries, criminal records, and problems with drug and alcohol. And what I did was just, this is not scientific, but I just lay these next to each other and talk about what do we know the outcomes from early childhood education are, and what do we see as the problems in our 18-year-olds. Janet Yellen was the Federal Reserve Chair, and she stated that 4 sources of economic opportunity in America, think of them as building blocks for the gains in income and wealth that most Americans are within the reach of those who strive them. The first recognized is resources available to children in their most formative years. The most consequential examples include early childhood education. And even though this was a talk on neurobiology, let's bring in the health economists, right? I think lots of people have seen this. James Heckman, Nobel laureate from University of Chicago, economist. And what he says is our economic impact, really we get the biggest bang for our return on our investment, biggest bang for our buck if we invest in programs targeted at the earliest years and months and preschool years of a child's life. So to develop those healthy communities, we really need to have the foundation of healthy child development. And this I always steal from Dr. McMahan, who is one of my heroes. Children are 100% of our future. And thank you. And I want to say one more thing, because John was talking about having a thing June 16th, 18th, around fathers. And I've had a bit of a hectic couple of weeks, but one of the things that happened was this. So this is my very first granddaughter. But this, my daughter-in-law had severe preeclampsia. The baby was born premature, and they were very sick. Now, my son actually had paternity leave. He took a month off. And one of the things that I always felt strongly about was that we should have paternity leave. But I have to tell you, I think this is the poster for it. Look at the serve and return that's going on there. Look at the bonding that we're seeing. And look, even though how sick she was, how much she's recovered and how happy she is. We need more of this and more support like this for our families.
Okay, I think we all want to go and hug every child we know. And starting at pregnancy, the first 3 years of life particularly, and get them in good early enriching childhood experiences starting with family. So thank you again, Dr. Swigonski, for coming and sharing that with us. We now are going to have a panel of some local experts along with Dr. Nancy and Dr. Deb McMahan, and for you to ask some questions, and we've got some questions for them. So give us a minute while we pull a few chairs up here for just a quick overview, and if you have any questions you would like to be challenging these guys with. Okay, so I'm going to ask those, we have 2 new people you haven't met yet, and so I'm going to have them introduce themselves and their title and role in their organizations.
Hi, I'm Amy Dawson. I'm one of the faculty at Fort Wayne Medical Education Program, and also recently took over the role as director of the Children's Health Collaborative. I was going to give a shout out to Lisa Cotton, but I can't find her now, so.
Hi, I'm Cherise Dixie. I am the clinical social worker at the Family Medicine Center under the Fort Wayne Medical Education Program. I serve as a social worker / emotional support therapist when needed. I also am an adjunct at St. Francis.
I think if you hold it close enough to your mouth, you will be in then you could be, yes, well, we're all learning constantly. So we have some different questions for you. The first one is, all right, I'm pitch hitting for Laura Dwyer, who sent me the question, so I've got to make sure I'm doing this right. Do you want to comment on any of the things that you heard or saw in either of the two presentations that either really jump out to you, that you have also seen in your practice or working with your patients, your clients, etc.?
We have a fairly significant percentage of patients who receive Medicaid, which you know is an income-based program. So that being said, a lot of our families that I've seen oftentimes are just simply overwhelmed. And so having the ability to do this, what do you call it? Pitch and serve and return. Baseball. The serve and return oftentimes just don't have the energy sometimes if they've worked all day or working a late shift or a couple of jobs, you know, so even if they're well intended, they may not have the emotional resources to do so. That's one of the things that struck me as I heard both presentations actually.
I really agree with that. I think when I'm in the clinic seeing patients, I have this phrase, I hope it's not offensive to anybody, but I feel like there's like a big ship with a small rudder in high seas. That so often when I'm seeing people as adults or as families, that I want to see them frequently to help out, because like anything could have happened in the 3 months since I saw them. You know, they lost their house, somebody got shot in the neighborhood, they lost their Medicaid, they got their Medicaid back. You know, so much happens that it's impossible for them to do all the things that are required to stay healthy. And it just really is a privilege for me to work with a group of people where I feel like I'm making a difference, because we take that comprehensive approach. But on the other hand, it just can't be comprehensive enough sometimes for what people need.
So I'm also a pediatrician, and one of the things that was always amazing to me was there's a great program called Reach Out and Read where we give books to families. And reading is kind of a natural thing that you would do with a child, perhaps. But what I found was many of my families did not know how to, quote unquote, read, right, to their toddlers. So they would actually sit there and try to read the words and get frustrated because that 1-year-old wouldn't pay attention, or that 2-year-old wouldn't pay attention. And one of the things that I found is that families don't naturally necessarily get the serve and return. You know, if your toddler picks up a book and opens it, you just go, see the doggy? What does the doggy say? Woof, woof. You know, it's that whatever the child is doing and directing, just making a comment or a comment about the book. And many times families need that role model because they have not seen that themselves. I had another example of where we had a young woman who her child was in foster care. She came to an appointment with the foster parents, and the foster parent was so, angry, frankly, because the young woman, when she fed her baby, basically just laid the baby down, handed him the bottle, and walked off. And the foster mother was horrified. And they finally had a conversation about this, and the young woman said, well, that's the way we've always fed babies in our family. And so when the foster mom started working with her and saying, why don't you hold him? Come here, and I'm going to show you how he'll look at you and he'll smile. And she goes, and the young mom was really surprised. She goes, he did smile at me. So I think role modeling is a really important part of our job. But when you role model, one of the things we know from academic teaching is you can't just do it and expect people to understand what you're doing. You have to name it. You have to say what it is that you're doing so that people can learn it as they see it.
One of the things I really appreciate about Dr. Swigonski's presentation is it takes what is really a lot of complicated new medical science and puts it into layman's terms. And the reason that's so important is that we used to think that all the innovations in medical research were really important for people like us to know, physicians to know, so that we could provide better care. But the reality is the information that we're learning now with the new ways that we have to be able to do research really is only effective if you guys do it on the front lines. And what you're going to find is if you can, and this is what's so great about these opportunities, Meg, for you to be able, I don't know how else you would have access to this kind of information, but what you're going to find is that your programs, if you look at this and absorb this information and go back and look at all of this information in the context of how you're doing your work, you're going to be less frustrated. And I always go back to the same, you've got to work with the physiology. You've got to learn, you've got to work with what we know is happening internally for a patient, for you to actually, or a person, client, whatever, for you to be able to have the most effective outcomes that you're really trying to get. So for example, if I asked you to be taller, how easily could you do that? I could encourage you, I could chastise you, I can incentivize you, but the reality is you're just not going to be able to be taller. You want to work with physiology. We know now that that is such a critical time, and we know the things that we can do to actually help that brain growth and that development in the child, even if it's not our own. And so this information is only helpful if you go back and as a group in your organization, talk about this stuff. Are we using the most cutting edge information about physiology, about how people are developing and organically participating in this world? Are we using our tools effectively, or do we need to change things up? The reality is, as we learn more and more about the body and how it works in the brain and everything, and I know that's really frustrating for people, but things are going to change, and you're going to have to be flexible with how you're doing things and be willing to change to accommodate what we're learning in research.
The second question that we kind of shared ahead of time, and if you all have questions, we're open to them, is we know that adverse childhood experiences, ACEs, have a tremendous impact on future violence, victimization, and perpetration, and lifelong health and opportunity. Please share what you are seeing and experiencing in your area of practice.
I think one thing that I've noticed is that oftentimes our practitioners don't know how to glean the information. If you don't have the actual test in front of you, what are you looking for? What types of questions should you be asking to glean this information? I'm a social worker, so I tell people I get paid to be nosy, ask a whole lot of questions. I'm comfortable with asking, but not every profession or every discipline is. And so I think sometimes we miss it. We miss the trauma and therefore miss an opportunity to address it and offer solutions or to work alongside the patient and families because of that fact. So that's probably one of the biggest things that I've noticed. And then two, consistency. What do we do once we discover it? I think we have some practitioners who may discover the trauma but don't know, oh my goodness, now what do I do with it? Where do I send them? If I send them or refer them to this particular agency, my gosh, they're backlogged for 3 months. What do we do? Which is a real issue, I think, around here, especially when it comes to mental health assistance. So those are probably the two most glaring things that I've noticed as it pertains to ACEs or identifying it here in our practice.
I could expound on it, but you know way more about it than I do. So I am one of probably one of our more typical physicians who's just learning about not only the adverse childhood experiences, but how do you actually screen for those in practice? And then what are things that we can do in our context to help build and support resilience? So it is my aspirational goal that we are starting to teach those things this year at the residency program. But this is a new field to me, just like it is for many other physicians.
So one of the things that I think is interesting is the child poverty rate and its impact on the social environment and parents, energy even to, again, interact with their children. And although the statistics are interesting, because in Indiana, our child poverty rate, and Dr. McMahan, thinks that it even went down in Allen County. What's not going down is something called concentrated poverty. So children who live in concentrated poverty. And what that means is not only are they living in poverty, but all of their neighbors are living in poverty. And what it does is really take the social capital out of the area where children are living. In other words, you always think about a long time ago, if you lived in a neighborhood, even if you didn't have much money, there would be the neighbor down the street who would always be willing to give you a ride or to make you a peanut butter and jelly sandwich. Well, what's happening now with children is those areas of concentrated poverty and where they're living are increasing. So not only they don't have resources, but the people around them don't have resources. And I think that's one of the things that's driving. You said, why are we having this? I think that is one of the things that is driving the continued problems that we have.
I see it all. In public health, we see it all. We see the impact of long-term trauma in folks. I see it, you see it, we see it all. I think the one thing and this is from a personal perspective, I think one thing I've had to really discipline myself, because I see incoming refugees, and you talk about sad stories. Those are some really sad stories. But what I've had to really discipline myself to do is not pity people. Because every time I pity someone, my faith dies a little bit, because the design is perfect. And every one of you raised your hand and said people have potential. So what I try and do is when I'm in these situations, when I have folks that are in some really desperate situations, believe it or not, I still try and discipline myself to have expectations of them. Because expectation implies competence. Expectation implies a belief that think you have something in you, that you can accomplish something. And so I just really encourage you, because I see a lot of times, I think it's so easy and natural to feel sorry for people and to pity them. And just remember, you think they have potential. They were born with potential. So have an expectation of them. Help them feel the success that you really, truly believe they already have in them.
Okay. You had one of your slides in there, the Center for Disease Control's safe, stable nurturing. It's something we've talked a fair amount in this group. We have a whole room here, a community full of wonderful practitioners, professionals who are on the front line. What should professionals like this, anybody in here, do you think should be doing to help families thrive? What are the opportunities you would like them to think about further, or that you think are in front of them?
We've started this pattern, have we not? One thing that comes to mind is that, everyone in this room has some sort of training to do what you do so well. Oftentimes what I see is there's a disconnect between the professional and the greater community. And so when you look at it as this is what we do, what we're passionate about in most cases, oftentimes our families, our neighbors, our leaders in the community don't feel the same or don't have the information that you have or see what you see on a daily basis, where I think can make a significant impact if we would do more sharing and educating to those people. Take it, for example, the opioid crisis that we have, which is horrific in and of itself, but until it got noticed media-wise and we started having these conversations among ourselves, did we see some significant change or monies being given towards it? I think there are other instances that we can have a similar impact if we in this room would share what we see with others on a more daily or more routine type of situation, so to speak. So that includes our politicians, the educators, and like I said, just our families even. You can have conversations that may change how they think or see a particular issue, and they may be misinformed, so you can provide accurate information that may down the road make a significant impact on how we address some of these challenges that we have.
Cherise, some of you probably heard me say this before, but I really like what you're saying, because I think I used to get really frustrated. I still do with the politicians. I agree with your slide, by the way. But I used to get really frustrated with them. And really, the reason the opioid issue is getting a lot of attention because it impacted the economy and the workforce. That's why. And the problem is the people who are on the front lines like yourselves are not the experts that are really informing policy. And I really realized my frustration with public officials, whether they be federal, state, or local, my frustration was really that I was expecting them to have a knowledge and an understanding they don't have. They're just like you and me, only they got elected, right? So they don't know what they don't know. And it's really, as Cherise said, it's on us to be really those kinds of folks that are advocating. How many people in here have written an op-ed? That's sad, because you guys are the experts, right? How many of you have sat down with a public official and really given them information that they could use to form a policy? All right, until half the rooms in this hand are going up, we need to work on that. You are the best advocates. You are on the front lines. You know what's working. You don't know what's working. So I totally agree with what Cherise said, but the other thing I think is you have to stay informed. Information is coming at you every day. You've got to find a way that you personally can keep up to speed with what's going on in your discipline and and collaborate with other folks so that you have a well-rounded understanding of what's going on and what research is being done.
I think what I love about Nancy Swigonski's slides, and every time I've heard her presentation, I'm just like, dang, how did I get that wrong last time? It's just like, no, I've heard this a lot of times. I should know it by now. But what I really like about it is how hopeful it is. I just like that the data informs what the problem is in a way that breaks it down as to what we should do about it. And I know that all of you here know more about what to do about it than I do. And I appreciate that you do. And as I run into people in the community, Lisa that I tried to introduce earlier is right there. She's been running into like 70, 90 businesses she's talked to now, and no one knows that we are 49th in public health funding in Indiana out of 50 states. 49th, 49th. No one knows that still. No one knows that we're 41st in outcomes, that we're 28th in childhood rankings for kids counts. They don't know that we are under-supported when we're trying to do not general programming in a Boyd, but when we are trying to make sure that no one falls through the cracks, that we completely close the gap and that all kids are successful. And you guys are the ones that know what to do about that. And it is so important that when you're talking to your friends and talking to, like you were saying, the elected officials, but just making that known. We need to be able to speak with common knowledge about what the issues are for kids and about what those remedies are and about how much it takes for us to become better. The top 10 states in the United States do not have a perfect handle on poverty and child development and they don't have a 100% rate of getting kids into kindergarten or preschool, or 100% of the kids aren't in high quality infant care. 100% of the moms are not reading to their kids, but they're in the top 10 states. So for us to get better, we just don't have to stay at the bottom. Why are we this low? How much does it take to get up to where everybody else is? So, and bridge those gaps.
So I talked a little bit about when Robert Duggar, the investment banker, came and talked at Grand Rounds, medical Grand Rounds. And one of the things people said is, but how can we do this? How can we get our state to actually invest in things like early childhood education? And he sort of laughed at us. And we had just gotten past like the Great Recession. And he said, do you know what happened during the bailout? Basically, all the companies that wanted bailed out and the banks got all their employees, they got all their family members, they got everybody to start calling Congress and saying, you have to do something about this. And guess what? They did something about it within 72 hours. And he said, do you know how many people either have a child, know a child, take care of a child? He said, if people would just say, we want to make children our priority, and we will have the political will to do this, you could do it in a heartbeat. So I have to agree with you, Dr. McMahan. How many people have written that op-ed? How many people have talked to their legislator? If you want preschool for the children in our state, you need to start letting the people know that you're going to vote for preschool. And it needs to be something that you talk about on a regular basis. So I think that we have inertia. It's interesting to say that the families we work with many times are overwhelmed because they have so many things going on. I think many times we are overwhelmed because we're down in the trenches trying to do that work. But the reality is that we're going to continue to be in the trenches until we all step forward and start to make that difference in terms of the political will and what do we think is best for the children in our state.
Salute.
Then my final question is, what is a critical message? We may have heard it, but what is a critical message that you want to leave everyone with today as they walk out?
You're important.
Dr. McMahan. Critical message. I think that it's multifaceted. It's not just one person or one group. It's going to take a lot of different entities coming together to collaborate to see some real change. I think that we have to pay attention and be mindful of what's being thrown at us as providers in terms of what we latch onto and regurgitate. The slide you had, it was your slide, it talked about the homicides numbers, and yet we were unaware of the accidental overdose death or numbers because it's not in front of us, so to speak, us being the community. So I think the critical message is to just continue to pay attention, to be alert, and be willing to be that change agent. You'll find some people who aren't comfortable being in the front. That's okay. You can be in the back and shove somebody else up there, but help them with the accurate message.
I'd like to hear what some of you are taking away. What did you all hear as the critical message?
Well, I think personally, as I have worked in the social world within my community, I am my community. I came here as not a refugee, but as an immigrant from Venezuela. So I attended the free clinics. I took my mom. I still take my mom. And so I am mindful that what they're going through is very normal and to treat it like that for them. Because when you don't, then it just blows up even more. So I agree, be mindful, be present, and listen. That's what I take away. Anybody else? I'll take the microphone to you.
So the Children's Health Collaborative, just to stand up. Then everybody's gonna know I'm in the bathroom when Dr. Dawson was trying to. The Children's Health Collaborative, our hope is that we serve as that hub for you to go for legitimate data to drive your initiatives. You guys know, like Dr. Dawson said, you're in the trenches. We want to help support you in the trenches. So if you go to our website, Dr. Dawson is a wizard with data, thanks to awesome presentations that we saw today. But that's where you can go to get data to drive your initiatives, to get your grant money and to argue your point. And I am going to be the advocate out there for each and every person in this room, in front of our businesses, in front of our politicians, in front of the medical community and our students in the universities. We have to push this initiative as people, and the Children's Health Collaborative is here to help your initiative. And as Dr. McMahan and Dr. Dawson know, once I get excited about something, I don't let it go. So if you need something and we're not giving it to you on our website, or we'll find it for you to help you push your initiatives. What I took from this talk today is be supportive. You know, our families don't always know the right thing until they're modeled or shown the right thing, whether it comes to safe practices or safety or providing nurturing
families to their children, or what does that mean? What does that look like? You can say that all the time, but families don't know what it looks like. And also stability. Help them with that stability. Their life is so unstable, and try to help them in those rough seas. Help them stir their ship so they can have some smooth sailing.
Any other comments? I would just add one very quick thing. Is you talked about how to talk to children. I'm struck by the fact that we are in an incredible library with his great sections of children's books. There's some great programming here as well that's free as a resource. And that may be something we should make available to help people access it very easily, because it could help. The tools are there. If there's no other questions or comments, we thank everybody for joining us. I'd like a last round of applause for all the people who helped us today.